What's up there, everyone? I'm Yelis. I am a cardiac arrest survivor. I've been living with a heart rhythm disorder for basically my whole life. In school, they actually, with a medical examination, the doctor noticed that my heart, was sounding a little bit different. And one thing led to another. And they saw that I have a heart disease called arrhythmogenic cardiomyopathy, or in short, ACM. And throughout my lifetime, I've had several ablations. In fact, I had 4 ablations. Now, from the 4, only 3 of them, they did burn, they did do something. I think the first one that they did on me, and I might get the age slightly wrong, but I was about like 11 years old. That was the first time that they did it. And then the last time was when I was 30. So that was about less than 2 years ago. I've went through the procedure under full anesthesia, but I've also went through the whole procedure under local anesthesia. You know, if you have a heart rhythm disorder, then your cardiologist might have put that on the table, the possibility of doing an ablation. In fact, maybe you have an appointment coming up where you're gonna go through that surgery. And I thought, given the amount of experiences that I've had with ablations, to make a video/episode on it. Now, I'm gonna share in this video/episode my personal experience as the patient going through this procedure. But I also invited Dr. Saenen, who is a cardiologist specialized in hereditary heart disease, invasive rhythmology, and in sudden cardiac arrest, so in sudden death. And he's actually my cardiologist. He did 2 of the ablations on me. And I invited him here in this video/episode to explain in between the more technical aspects of ablations. Now, let's, start, right? And let's do that by letting Dr. Saenen actually explain, what is an ablation.
In order to understand an ablation, first we have to know that the heart is an organ that is driven by electrical stimuli. And these electrical stimuli spread out over the heart like an electrical circuit. So actually the heart is a giant electrical organ is one giant electrical circuit. And through this circuit, these electrical stimuli that are generated inside the heart by the heart itself, they migrate from structure to structure, from the atria towards the ventricles, and they will cause the heart to contract, and these contractions occur about 100,000 times a day. And this happens 1,000 times a day exactly at the same in the same way. So this is a very organized, very structured, very concerted system to allow the heart to beat in a very stable way. When this occurs, this becomes abnormal, this is what we will call an arrhythmia. And this will cause the heart to beat either too slow, either too fast, or when the regularity of the heartbeat is lost. This is also a condition that we call a dysrhythmia or an arrhythmia, or when the electrical stimulus that drives the heart arises from an abnormal focus, so an abnormal locus in the heart, an abnormal place in the heart, or when it follows an abnormal trajectory through the heart. So as I mentioned, it always passes through the heart in the same way, following the same path, the same trajectory. So sometimes this stimulus will go around in a circular fashion, which is an abnormal trajectory, and this will also cause arrhythmias. In order to treat arrhythmias, there are actually a couple of strategies for the cardiologist. And the first strategy is actually quite easy. It is lifestyle modification. Sometimes patients do have arrhythmias that are triggered in certain conditions, such as with exercise. Some of them, malignant arrhythmias, occur during exercise or emotional stress. So those patients will be treated by not doing exercise. Sometimes arrhythmias are triggered in conditions where people have taken alcohol or drugs. So of course, avoiding alcohol and drugs is another strategy to avoid arrhythmias. But in many cases that is not enough. So of course the second strategy is that we give medication such as beta blockers or antiarrhythmic drugs that will stabilize the electrical functioning of the heart reducing the risk for having new arrhythmias. And when those arrhythmias are there, some of those medications are also able to stop the arrhythmia that would otherwise not occur without the medication. And then, of course, you have strategies to prevent sudden cardiac death due to arrhythmias, which are due to, for those, we have pacemakers and ICDs. And then finally, in the arsenal of the cardiologist, there are these techniques that we call ablation. As I mentioned, the heart is one giant electrical circuit, and these arrhythmias typically follow an abnormal circuit in the heart. So if we can identify the abnormal trajectory of those arrhythmias, of the stimulus that the stimulus follows within the heart, we can disconnect this abnormal circuit inside the heart, preventing the stimulus to go in an abnormal way through the heart and activating the heart in an abnormal fashion. And this disconnecting of this circuit of the arrhythmia is what we call an ablation.
All right, so maybe when I was giving a little bit of this introduction of why I wanted to create this video and share that I've had 4 ablations, you might wonder, like, why 4 ablations? Again, only 3, they actually did something. Now, I'm just sharing my experience, right? It's gonna be different for you. A lot of the things that I'm sharing from my personal experience will likely be different for your specific case. But in my situation apparently is quite tricky. I know the first time when they did an ablation and they put me under full anesthesia, so completely to sleep, that the actual extra rhythms, right, the errors that they need to actually know where they need to burn, that it disappeared. And they tried to artificially awake them again with, I think, injecting adrenaline in me. But it didn't do anything. It didn't work. So that's one of the reasons. Then they did it under local anesthesia. The problem there was that it was actually very hard, apparently, to find the right spot where it was coming from. The errors, again, were coming from a lot of different spots in my heart. And that procedure was with Dr. Saenen. They did burn there, right? That was when I was under local anesthesia. It did disappear, but then, yeah, after the surgery, it came back again. And a reason why it can come back is that they didn't burn deep enough. And it makes sense, right? In the beginning, I mean, this was explained to me. They don't want to burn all the way very, very deep. They want to do it as little as possible to cause the least damage to you, right? And then I had another ablation, but then under full anesthesia, because they localized the spot where it was coming from. They burned again, and again the same happened. It disappeared, but it came back again. This can lead to the question, how many ablations can one actually have? And I know exactly the right person to answer that question.
The golden rule in what we try to do is to treat patients with as little ablations as possible. Because as I mentioned, there's all the tissue that you take away, of course, you want to cure the arrhythmia with as little damage to the heart as possible. And of course, if you have to do more and more ablations and more extensive ablations, at a certain point, of course, this can also affect the global function of the heart. And of course, if you have to just ablate just one little spot to try and take away extra systoles, that usually is not a problem, and you can do this repeatedly. But if you have to ablate extensive parts of the heart because they are globally pro-arrhythmogenic, this of course will cause loss of functional tissue, and of course there's a limit to that. So as little ablations as possible. Sometimes it is true that if you do an ablation, you see a reduction of the extrasystoles, and after a couple of years, the amount of extrasystoles rises again. It is sometimes necessary to go back in and to do an additional ablation. That usually is not a problem. Yeah, it all depends also a little bit on the substrate, on what is happening. For instance, in patients that had a myocardial infarction where there's a lot of fibrosis or scar inside the heart, there, of course, you want to get rid of the malignant arrhythmia circuits by ablating again as little as possible, but sometimes you have these large patches of the heart that is pro-arrhythmogenic with multiple circuits, and then of course you have to do a more extensive ablation to try and get an electrical balance.
All right, so let me run you now through how the procedure looks like, how it feels like. First of all, I would also like to add something of going to the hospital, because it's part of the whole thing of going through this procedure, right? I've spent some time throughout my life in the hospital, and I've just gathered some insights and hopefully some pieces of advice and tips to make that experience slightly more comfortable. Now, in my case, I had to be a day earlier in the hospital. I mean, just to get me completely ready, to put the IV line in my arm, to get all the paperwork and everything done. So I was just all completely ready to go first thing in the morning for the procedure. Now, again, the hospital, no one goes there for fun, right? Trying to make it a little bit more fun and more enjoyable and at least more comfortable and less stressful, that is something that you can do. For example, what I have done so far all the time when I had to be there a day earlier is I bought like something that I really, really like eating, and for me that's sushi. So I bought a box of sushi, took it with me to the hospital as a treat for myself for going through that, for putting myself through another surgery, another procedure. And it's something that makes me not per se look forward to it, but it's something that makes it, again, a little bit more pleasurable. Another thing that I can recommend is to take something with you that you find very, very fun. Because, there's not a lot to do in the hospital. In my case, I actually really like playing video games. I will say, take something with you when you watch something, when you consume something that is not very dark and grim and heavy, because that's going to inflict emotions like those. So something light, something funny, something that lifts up your mood. Like, for example, with the video games, I play like very cozy games that are just very stress reducing, you could say. Also, if you have to be a day earlier, if some company can come and visit you, if your partner, friends, family can come over and just keep you company, that's really, really awesome. Makes the place a little bit more warmer. Also, just having a loved one around you is just really good for us when we are going through a stressful moment. Now, other essential things to take with you to the hospital: earplugs. Never go to the hospital without earplugs. There is noise, right? There will be noise in the hospital. Also, a sleeping mask. Also take that with you. Another thing that I always take with me is my e-reader. During the night when I can't sleep, I can just read. There's a little light in it, so I don't have to turn on a bigger light and with that wake up potentially my roommate in the hospital. Or an audiobook, also great in a way to have with you. And last but not least, and this might sound a little bit funny, but take your pillow with you. Again, make it as comfortable as you can, and taking your own pillow with you can really be an essential part of making it more comfortable and less stressful. So before we are gonna go through the rest, right, the pre-surgery, the actual surgery, I just want to take a short moment. If you feel so far that you've gained something from this video, consider supporting this project. The more support this project gets, the more I can do with it. Leaving a small donation using Ko-fi, which is a place where you can give me a virtual coffee, even as little as €2 or dollars or whatever currency that you have, keeps this project alive. Now, I'm also actually working on memberships, so that you can also check that on Ko-fi. So you have different membership tiers with different perks. So you can leave a one-time donation, or you can choose one of the tiers and become a monthly subscriber. In the description, I will place a link for you to find the Ko-fi page. You can also go directly to heartwarriorproject.com/get involved to find the same information. Now, besides the donations, we also have merch, like the hoodie that I'm wearing here. This is just with the logo of the Heart Warrior Project. It's a very, very comfy hoodie. We also have t-shirts because, spring, summer are coming with different designs. Or we also have mugs like this one. I'm also working with another graphic designer to create more designs for our merch. The merch you can also find located in the description or by going to the same link, heartwarriorproject.com/get involved. So let me now talk about the pre-surgery. When they actually wake you up in the morning and they say, it's time for the surgery. Now, the moment when they're about to ride you in your bed to the surgery room is it can be a very nerve-wracking moment. I would also say, it's very, very normal to feel nervous. Now, I'm actually releasing very soon an episode with Paige Arnone. She works with first responders to help them cope better with stressful situations and with anxiety. She's also starting to be more active and working with cardiac arrest survivors. Now, in that episode, Paige will run through a variety of different techniques to help you in stressful moments and when you feel very anxious. I can recommend you to check that episode out as well because it's very, very practical and it can help you greatly in moments like that. Now, one of the things that helps me to calm my nerves is to start talking to the people around me, to just ask them questions, what they're doing. If you have great people around you, they will also be aware that it is quite a nervous experience for many people and they will also actually start chatting with you. In addition, if you feel nervous, if you feel some fear, some worries, honestly, just wording it to the people around you, that by itself really helps to just say to them, I'm really feeling nervous right now. If they know, they will also pay more attention to that. The last thing that helps me is to surrender to the experience and to put all your trust in the people around you. And again, this can be hard, right? To let go in a way of control. But at the same time, if you don't constantly resist, then that fear that you might be feeling, that nervousness that is built up by that fear that you might be experiencing, also reduces. So completely surrendering to this moment, to that moment that is happening, and just saying like, I'm here now and this is happening. And I'm gonna put all my trusts in these people. They know what they are doing. So have trust in them. Now, there are, of course, different kind of ablation techniques. And let's actually let Dr. Saenen explain the different ablation techniques that they have.
It depends a little bit on where the arrhythmias are occurring. So, for instance, if the arrhythmias occur inside the atria, then the main arrhythmia is atrial fibrillation, then you have actually the choice between heating and cryo energy. The cryo energy is delivered through a balloon, so it is actually a quite bulky, large catheter. So putting small lesions inside the heart with the balloon is very difficult. There are, of course, these catheters that also create an ice ball at the tip of the catheter, but those are usually not used for arrhythmias that need a line ablation or a focal ablation. Usually for those we use radiofrequency energy, heating the tissue at the moment to destroy the tissue in a very selected spot. Often we get the question, of course, from patients, okay, you are destroying tissue. How is this going to affect the function of the heart? Of course, the electrophysiologist wants to cure the arrhythmia by causing as little damage as possible. So we are always very selective. We are not just burning around or freezing around. It has to be done with a lot of thought to try and solve the problem without causing harm to the overall structure of the heart, at least as much as possible. In the ventricles, at the moment, we are not using cryo. It is because of the balloon structure. Usually there we use the RF energy. Yeah, so the heating energy. There was a third one also, which is quite new. It is another way of causing damage to the tissue. And the way we are doing it is what we call electroporation. So by giving electrical impulses to the tissue, you can actually porate the tissue so it becomes leaky. And if these cells become leaky, they cannot sustain themselves, so they will go into programmed cell death, so they will shut themselves down. And this shutting down will also cause a lesion. And if it is in the right exact spot, then of course this can also disconnect an electrical circuit that otherwise would have generated or propagated an arrhythmia. And this PFA, this is the pulsed field ablation technique that is used for electroporation. You can use it in the atria, and there's also more recent data that you can also use it in the ventricles, and it causes another kind of lesion. It is more safe than the thermal therapies. So it has these advantages, but at the moment it is quite new. We don't know everything about it yet, although the experience worldwide is increasing quite rapidly with PFA, also in the ventricles.
Yeah. Why is it more safe?
If you're causing thermal lesions, either by heating or freezing, you cannot stop the heat. So if you push heat inside the tissue, you cannot directly measure how deep the heating is driven into the tissue. So you have always the potential to causing collateral damage in structures that are very close by the tissue that you are heating or freezing. If it is freezing, usually the collateral effects are transient, but not always. For the heating, it is if you burn something, it is gone. So there are these potential complications, and we have a lot of systems in place to avoid these kinds of complications. But the risk is always there because, of course, you are pushing heat inside the tissue. Every patient is different. So also for instance, the thickness of the wall of the heart is different in many different places, but also it differs from patient to patient. Also the fat around the heart that causes a change in energy dissipation is also different in each patient. So it is so you have to put and we all put a lot of effort in place to try and deliver these lesions as safe as possible, but there's always a risk for complications.
Yes.
So that also brings us to the fact that there's always a balance that you have to make between wanting to try and treat the arrhythmia, but also not causing harm. There is always this balance, and for each ablation point that the electrophysiologist puts inside the heart, you have to think about, if we put this ablation point, what is the potential benefit? And you have to weigh it against the potential complications, the potential downsides of where you are burning, or where you are putting your cryo lesions, or where you are putting your pulsed field lesions. And so for the pulsed field, so this electroporation technique, so it doesn't have these thermal effects. So there is a little bit of heating, but it is very minimal, and so this energy is also more cardioselective. So it is more selective to the tissue of the heart. So adjacent structures are less affected by pulsed field ablation. So it tends to be more safe.
Now this leads us to, how does the procedure actually feel? Now, of course, if you're under general anesthesia, so you're completely asleep, you're not gonna feel anything of that. So this part doesn't really matter if they said that they're gonna do that for you. But if you're under local anesthesia, let me share how that felt and how that went. Now, one thing that is good to note is that pain is quite subjective. So there might be things that I will share that were not very painful for me, that might be more uncomfortable for you. And of course, the opposite is true as well, right? How we perceive pain has a lot to do with how, for example, we sleep, how we emotionally feel. The people around us also can really have an impact on how we experience pain, and also how we can just look and think and feel about the procedure in general. So again, pain is quite subjective. What I still remember very well is when they put the catheter in your groin, in the vein or in the main artery. I know that they also can do ablations in different veins or arteries, but I think it's quite common actually to do it in the artery in the groin. All my ablations, they've done it there. So putting the catheter in there, so that's actually how they can reach the heart. That is, I mean, painful. It's not pleasant. Especially in the beginning, I feel like it took more force to kind of go up. That was slightly unpleasant. Now, it doesn't last, of course, that pain. Now, when they're actually making their way up to the heart, it's not per se that you can feel the catheter going through your body, but you feel just at the groin that they're like just moving it and just like pushing a little bit, and you're feeling that pain over there the whole time. And basically throughout the whole surgery, that keeps happening. In your heart, you don't feel anything. If I remember correctly, Dr. Saenen actually said like, yeah, you don't have any pain receptors in your heart. So whatever they're doing there, you don't notice anything at all there. Now, one thing that I do think many people are curious about is like, how does it actually feel when they burn? Does that hurt? So first of all, doesn't hurt. Like, didn't feel really any pain or something. They do, when they are about to burn, tell you to not move at any costs at all. So at that moment, I was like really laying there as still as possible, because if you start moving all of a sudden, they're gonna burn somewhere incorrectly, and they don't want that, of course. Now, when they do burn, the sensation that I experienced, for some reason, I like my throat. I felt it very strongly in my throat, and it feels like you have a sore throat in a way. Again, not to the degree that I would call it painful, but also more like a weird and a bit of an uncomfortable sensation. They do also told me in the beginning of the surgery that I might get back pain because you're laying on a table for X amount of hours. And I did actually get quite a lot of back pain. Now, they said also, if that happens, we can actually give you something to reduce the pain in your back. So after some hours, I was like, you know what? This is getting, very unpleasant in a way. So please give me something. And that really helped. All right, so the surgery is over. You survived it. It's done. A question, of course, that I guess you might have is, especially maybe after hearing that I've had 4 ablations, is that common that it just disappears, that it's in a way all been done for nothing? Do ablations last? Well, let Dr. Saenen actually explain that part to you.
If we go back to the model of the heart as a giant electrical circuit with abnormal circuits being there, for one specific arrhythmia, if you are able to take away the circuit through ablation, that circuit is gone and will never come back. If the ablation was successful there, that arrhythmia that uses that specific circuit, whether it is a circular circuit or it is a focus firing causing extrasystoles, that will never come back. Yeah. So, for instance, in patients with atrial fibrillation, if you are able to take away the main mechanisms causing atrial fibrillation through ablation, those mechanisms, if you are able to take them away, they will stay away, if the ablation is efficient and successful. But of course, sometimes for atrial fibrillation, the main reason for developing this arrhythmia is aging. It's just an aging effect. It is something that occurs in all of us getting older. Our muscles tend to be a little bit less flexible. Also the joints, and also in the heart, the electrical functioning of the heart is aging as well. And one of these arrhythmias arising from that is atrial fibrillation. So if you are able to take away the predominant reason for developing atrial fibrillation by doing a pulmonary vein isolation, in many patients that's enough. But in some patients, the aging effect also affects other parts of the atria that will also become pro-arrhythmogenic and that will again cause atrial fibrillation somewhere down the line. And these are typical patients that also have other risk factors such as diabetes or sleep apnea or arterial hypertension. So yes, the ablation was perfectly successful. We did everything that we needed to do, and the patient was cured for a couple of years. But due to the aging effect, somewhere down the line, in some patients, not in all, 10 years later, and there's atrial fibrillation again. Was the ablation not successful? No, it was successful. It's getting dark.
Oh.
Yeah. So the ablation was indeed successful, but there's another problem that is progressing inside the heart, which is the aging effect of the atria. For PVCs, if there's one focus, so for extrasystoles, if you are able to ablate the focus, usually that cures the patient if you are getting close enough with your energy and you're in the right spot. Usually this does not reoccur. But in some patients, there's an underlying cardiac disease, such as a cardiomyopathy, so a muscle disease that causes other foci to arise in other spots. And then it can also reoccur. But that's for extrasystoles, usually it's not the majority of the patients. Yeah?
Okay.
For patients that have ischemia, so in myocardial infarction patients that have a scar somewhere in the heart due to a myocardial infarction, you can take away the circuit that is causing the ventricular tachycardias. If you would be able to freeze the ischemic process in the heart, causing it to no longer evolve, if you're able to take away that circuit, that ventricular tachycardia will never reoccur. But of course, again, also ischemia, ischemic heart disease, is also something that is usually a little bit progressive. So other circuits may arise in other parts of the heart. And if at that time they are not important and you are not able to induce ventricular tachycardia anymore, we leave it. But we know that in some of those patients, a couple of years later, these circuits evolve and become clinically relevant and also cause ventricular tachycardia. And at that time, you have to go back in and also do a new ablation to control the ventricular tachycardia.
So, right, you woke up from your general anesthesia, or after the local anesthesia, you're being brought back to your room, which is a nice feeling. If you feel generally quite well and good, you might be tired, of course, but have company, have someone come over and just be there with you, even for a little bit. It's really nice to just talk with someone, also to kind of just share and just let out how you're feeling, how the surgery was going if you were under local anesthesia. It's just nice to just talk and share it. And also, another reason why I think it's good to have company with you, and I really hope that they figured better things out somewhere else in the world than in Belgium. But in Belgium, so far at least, because you still have this catheter in your groin, in your main artery. So they have to take that out, right? Now, it's a main artery, right? So if they take something out, there's a lot of blood coming out of there. Now, here in Belgium, what they use, I don't know how it's called, but it's one of the dumbest machines ever. It's such a dumb thing. Again, here's where it might be personal. Maybe you will have no issues with it at all. So they take it out and then they put this really clunky machine on you that has a lot of pressure, which makes sense, right? Because you need a lot of pressure to stop the bleeding, and they leave that on you. The thing is that this machine is just hard pieces of plastic. So you're laying in bed, but it's not like bending with you or with the bed or anything. So you're laying like very, very uncomfortably in the bed with this machine on you that's putting so much pressure on you. Like you really can feel it hitting like on your bones and everything. Like this is something that is being created and designed by a person who never in his life went through an ablation. If they could change this, the whole experience of going through an ablation will be a lot nicer, I think. Now, after 15 minutes, the nurse will come back and just lift a little bit of the pressure off, which feels really nice. But that's what they're doing gradually. So every 15 minutes they come back, check, lift it a little bit to put the pressure off, and then at some point it's completely off. Now in my case, every single time when they had it all the way off and I was like, oh, I'm free, it started bleeding again because probably of the blood thinners that they gave me through the surgery. And so they had to start from zero again. So again, it's such a stupid and annoying thing to go through. And this is what I mean when it was nice when my girlfriend was actually with me when that was happening, to have someone to talk to. So here also, it's about keeping yourself in some way busy and distracted while you are enduring this uncomfortableness. Like, it's really just uncomfortableness. Now, after that, you are not allowed to walk for 24 hours because of, well, they don't want you to have any pressure on that part of your groin, and with the main artery being able to just very easily just open up again. So you just have to stay in bed. And then the next day, a doctor will actually come to you, because mostly the next day you're just able to leave the hospital and go back home. Mainly the doctor just has to come and check on the wound and to see if it's not like swelling or if it's not irritated or anything at all. If that's not the case, you're actually able and allowed to leave your bed and to walk around and to go home, which is the best feeling ever. Now, they will also, I think this is just a standard protocol for everyone. They will also tell you to not do any heavy lifting for at least 2 weeks, if I remember correctly. Again, all about not putting extra pressure on the wound in your groin for it to not possibly open up again. Now, one last thing that I also want to share is that maybe for you, after the surgery, the doctor also comes to you and says, like, it's came back, right? The extra heartbeats, the extra heart rhythm, it came back. Or they might tell you, like, okay, we weren't able to actually localize it or get or burn or do anything. After a while, if you have to hear that multiple times, which I have heard now 3 times, or even 4 times in a sense, I feel a certain kind of fatigue thinking about another ablation. Yes, the long-term benefits are there and are real, but just of the fatigue of like having another possibility that they might again not succeed and that it might again not have worked. A shift of perspective that I've recently had is that, yes, in a way, it's been unsuccessful, but in another sense, it's not been a complete waste either. Every time when they've done another ablation, they've had more data. There was another data point that they were able to use to get closer to actual success. Even if in the end the ablation will not succeed the first time, that doesn't mean that the next time it might not work, or the third time. But each time having to go through it again is tiring, of course, but it is extra data for your cardiologist to get closer to the actual final treasure chest, you could say. Now, finally, let Dr. Saenen explain what are the possible side effects of doing an ablation.
Well, usually if the ablation is performed well, after the ablation, eurythmia is gone, the symptoms should be better, and it's not like a surgical operation. It's just via the puncture access in the groin. So usually, if everything is well, there shouldn't be that many side effects after. Having said that, with the RF ablation, sometimes so this causes inflammation, and this inflammation after a procedure can also cause inflammation of the structure around the heart, which is the pericardial sac, and this can cause inflammation of the pericardial sac, which we call pericarditis, and this can sometimes give rise to this to chest pain, like a stinging pain on the chest for a couple of hours after the procedure. And for that, of course, we give medication to control those symptoms. But other than that, usually there is not, of course, besides of the complications, because there's a whole range of complications that may occur But besides that, usually the ablation is a very elegant technique with very few or very little symptoms afterwards. You can treat the arrhythmias. Yeah.
All right, and that is it. If you are about to go through this surgery, I wish you luck. I wish you so much just strength. And let me share also this with you. This too shall pass. That's a quote that I actually have tattooed on my arm because it has helped me through many situations in life. And it was also a quote when I was lying on the surgery table under local anesthesia that I was constantly repeating in my head. This too shall pass. You know, if there's any thoughts or any worries or just anything that you want to share, then you can leave a comment down below. Also, yeah, if you found this video / episode helpful, I can use all the support that someone can give to keep this project alive. So leaving a donation using Ko-fi, either with just a one-time donation, or checking the different membership tiers that we have and becoming a monthly subscriber helps this project to stay alive. Or, well, yeah, check out the merch that we have. We got different options. Got, mugs, bottles, t-shirts with awesome designs to check out. So check the description to find the link to Ko-fi or to the merch. And anyone who will come to support the Heart Warrior project, truly thank you so much. But with that, I hope to perhaps welcome you on another video / episode. Until then, take care.